We left behind goiter a while ago, so let's start again with goiter. Goiter is the enlargement of the thyroid gland. Thyroid enlarged in order to maintain the patient in a euthyroid state, so it is a compensatory mechanism, and there are places that are endemic in goiter. Clinically, they are asymptomatic. I'm sure you've seen a lot of people with enlarged anterior neck mass who are asymptomatic and they go around in their daily activities. These are usually soft, diffusely enlarged thyroid gland. Diagnostic usually euthyroid with normal TSH and low normal or normal free T4 levels. RAI uptake, there are patchy uptake with areas of hot and cold nodules. Fine needle aspiration cytology is recommended who have a dominant nodules for us to rule out malignancy, because there are cases that has malignancy in those with hard nodules. CT scan evaluates the extension of the to the retrosternal area and evaluate the surrounding structures, especially the airway. Treatment for small diffuse goiters requires only observation. For large one, we can go with dissection, surgery. Sometimes smaller nodules, we can use exogenous thyroid hormone to reduce the TSH stimulation. Now let's go to the solitary nodules of the thyroid. Majority of the thyroid nodules are benign and do not require treatment. Pain is unusual, and when present, we should be cautious. Be suspicious of the intrathyroidal hemorrhage or medullary CA, complaints of a dull aching sensation. Hoarseness is a worrisome, and it may be secondary to impingement or involvement of the recurrent laryngeal nerve. Usually, these are caused by malignancy. The risk factor for malignancy are exposure to ionizing radiation, if there are family history, and other malignancy related to thyroid. I hope all of you knows how to examine the thyroid. The best position is at the back of the thyroid, at the back of the patient. Anterior neck mass that moves with swallowing, as you can see on the picture to the right side of the screen, that's testing the swallowing movement of the patient. Cervical lymph nodes should also be assessed, especially the different area at the posterior triangle of the neck. Fine needle aspiration is the single most important test for solitary nodules. Take note, it's for solitary nodules. If difficult to evaluate, you can use ultrasound guidance. Some specimens are fixed with alcohol, others are air-dried. They are seen by the pathologists and are either categorized as benign, suspicious, malignant, or non-diagnostic. There is approximately 1% false positive and 3% false negative in an FNAC diagnosis. Laboratory tests, also the TSH level is being determined, especially to evaluate a euthyroid patient. Serum thyroglobulin cannot differentiate benign from malignant. Take note, they cannot differentiate benign from malignant. Serum calcitonin in medullary thyroid CA is a must. And ultrasound is the most useful to evaluate, especially the lymph node. Detecting non-palpable thyroid nodule is also through an ultrasound. CT scan and MRI are rarely used in thyroid. Scanning of the thyroid is rarely necessary, especially if you can palpate it and you can identify it by ultrasound. Management, of course, is thyroidectomy, simple thyroid cyst aspiration. You can repeat aspiration by up to 3 times, although some would do it only twice and then refer it already for thyroidectomy. Thyroidectomy should be performed if nodule enlarged on TSH suppression and causes compressive symptoms. And also some of them are being done for cosmetic reasons. Now let's go to the malignant thyroid diseases. These are the papillary, follicular, Hürthle cells, medullary, and anaplastic carcinoma. Of course, there are some metastatic, but that's a rare condition. Papillary carcinoma, 80% of all thyroid malignancy is a papillary carcinoma. That's good because that is more or less a benign or what we call a slow-growing malignancy. Occurs more often in women, 2:1, and usually presents from age 30 to 40 years of age. Most patients are euthyroid and present with a slow-growing, painless mass in the neck. Some will not be bothered by it. Dysphagia, dysphonia are usually associated with local advanced invasive disease. Lymph node metastases are common, especially in children and young adults, and may be a presenting complaint. Take note, it is through the lymph node that papillary carcinoma metastasize. Diagnosis established by fine needle aspiration of the thyroid mass. And distant metastases are uncommon at initial presentation but may ultimately develop in up to 20% of the patient. The most common site, of course, are the lungs, the bones, the liver, and the brain. By pathology, generally hard whitish and remains flat on sectioning. Diagnosis established by characteristic cellular features, the grooving or crowded nuclei, an intranuclear cytoplasm inclusion, leading to the designation of orphan anenuclei. Samama's body is also one of those diagnostic features of a papillary carcinoma. They rarely invade adjacent structures such as the trachea, esophagus, and recurrent laryngeal nerve, but they can. Surgical treatment, most of them are being treated with total thyroidectomy, but for small tumors, there is a debate whether a lobectomy or mastectomy can be done, especially less than 1 centimeter. For staging of papillary carcinoma, take note the age of less than 45 years old. If you have no distant metastasis, you're only up to stage 1. For distant metastasis of people less than 45, that's stage 2. For greater than 45, that's when we use the other staging, the stage 1, 2, 3, and 4. And the survival is very good. Follicular carcinoma accounts for 10% of thyroid cancer and occurs more commonly in iodine-deficient area. Once again, women are more affected than men, and the mean age is 50 years of age. They present usually as solitary thyroid nodule, occasionally with history of rapid size increase and a long-standing goiter. Pain is uncommon, as in most of the thyroid malignancy, unless hemorrhage in the nodule has occurred. Unlike papillary cancer, cervical lymphadenopathy is uncommon at an initial presentation. Why? Follicular carcinoma has a hematogenous spread. In less than 1% of the cases, follicular cancer may be hyperfunctioning. Fine needle aspiration cannot distinguish benign from follicular lesion from follicular carcinomas. Therefore, preoperative diagnosis of the cancer is difficult unless distant metastases are present. Sometimes large follicular tumor in older men are more likely to be malignant. Malignancy is defined as the presence of capsular invasion and vascular invasion. Take note, malignancy is defined by the presence of capsular invasion and vascular invasion. In the absence of these two, these are only considered follicular tumor. Surgical treatment, of course, thyroidectomy, lobectomy for benign, and total thyroidectomy for malignant. Hürthle cell carcinoma accounts for approximately 3% of all thyroid malignancy. Under World Health Organization classification, considered to be a subtype of a follicular thyroid cancer. These are characterized by vascular or capsular invasion and therefore cannot be diagnosed by fine needle biopsy. They differ from follicular carcinoma in that they are more often multifocal and bilateral, and approximately 30%. Usually, they do not take up radioiodine and are more likely to metastasize to local nodes. Distant sites and are associated with higher mortality rate than the usual follicular adenoma, although the management is similar to follicular adenoma. Some pictures of the Hürthle cells. Postoperative management of differentiated thyroid cancer, thyroid hormone such as thyroxine as replacement therapy in patient after total or near total thyroidectomy is done, and TSH suppression